Good morning, Dr. Stadnik. I'm going to go ahead and open the lobby. Thank you.
Hey, good morning, everyone. Welcome to Wednesday Morning Rounds. A couple of reminders. We'll have rounds for the next 3 weeks. Next week is a quarterly staff meeting, so an invitation went out this for the medical staff, so please register and attend. There'll be 2 more rounds after that, and then we'll break for the summer. So today, it's my pleasure to introduce the EP team. So we have 3 of our EP fellows, Dr. Salmeen, Dr. Weng, and Dr. Tan. They're going to give us some updates from the Heart Rhythm Society conference that occurred a couple weeks ago in Louisiana. So we'll turn the podium over to them. So Dr. Salmeen is going to start.
Thank you, Dr. Stadnik. So we're going to be talking today about landmark trials that were presented in the Heart Rhythm Society conference a few weeks ago. I'm going to go first. I'm going to be talking about the LEAF study, which is a pre-ablation weight loss as a predictor of atrial fibrillation ablation outcome and the liraglutide effect on atrial fibrillation. A little bit of background. So we all know that obesity is an established risk factor for developing AFib and recurrence of AFib after ablation. In fact, in patients who are obese, the success rate or freedom of AFib after a post-ablation ranges between 40 to 50%, whereas in the general population, it can go up to 80%. Why and how obesity affects atrial or has an impact on AFib? The hypothesis is that it merely stretches the atrium, causing structural and electrical remodeling, mainly of the left atrium. And therefore, the most recent atrial fibrillation guidelines in 2019, they actually implemented Class 1 recommendation for weight loss and risk factor modification for management of atrial fibrillation. A little bit about liraglutide. It's a GLP-1 agonist that is indicated for weight management for adults with a BMI of more than 27 who have at least one weight-related complication. And there was actually a study done on dogs that showed liraglutide suppressed AF inducibility and it improved conducting velocity as well. This is from the Legacy trial. It's just showing us that the effect of goal-directed weight management in AFib. On graph A, you can see that the red graph is weight loss of more than 10%, and they have those patients have freedom of AFib more than the rest without antiarrhythmic medications or ablation. The blue would be 3 to 9% weight loss, and the purple less than 3%. So more than 10% weight loss had a favorable results when it comes to freedom of AFib. On the right side, which is B, it showed the total AF freedom was also like similar results, but with total AF freedom for patients who had weight loss of more than 10%. So we know from this that weight loss had favorable effects when it comes to freedom of AFib. This is a trial that was published in 2021, actually, so it's quite recent. It showed impact of pre-ablation weight loss. Now we're talking about ablation here, weight loss and PVI. This actually study, they talk mainly about cryoablation. And on the left-hand side, you see that The red graph, which shows more than 6% weight loss, they have almost 100% freedom of AFib after ablation in obese patients. And interestingly, on the right side graph is even non-obese patients had favorable results when it comes to freedom of AFib after ablation. It's more or less all kind of on the right side, all weight losses, whether it's more than 6% or 3%. It's just the weight gain that didn't have good results when it comes to freedom of AFib. This was a retrospective cohort study, so it's not randomized, and there was no active management for weight loss. It was mainly patient-directed. So we know now that obesity is bad for AFib, and we know now that weight loss has favorable results when it comes to freedom of AFib after ablation. These are the same study. They're showing the adjusted odds ratio of the impact of % weight loss. So whether you have persistent AFib, paroxysmal AFib, history of PVI, obese or non-obese, they all had good predictors for freedom of AFib, except for non-obese persistent AFib with no prior ablation. That was not a good predictor for freedom of AFib. If you go back to our study, so our study is looking at to compare the risk factor modification, the standard one as per the guidelines, or if you do risk factor modification and you add liraglutide treatment prior to ablation. So we're doing some active management here in order to achieve weight loss. We're looking at male and female with either paroxysmal or persistent AFib who are willing to undergo ablation, more than 18 years old, with a BMI of more than 27. They have to follow up at the University of Miami. They ended up randomizing 65 patients with a 3-month pre-ablation period. Group 1 is mainly just risk factor modification, and group 2, where they added the liraglutide. And this is how they did the risk factor modification. It was mainly led by a nurse practitioner. They followed up the patients either in the office or telepath, either once a month or once every 4 months from enrollment to month 0. Weight management and exercise regimen included 30 minutes for 2 to 4 times a week, and there was intensified kind of risk factor control, including dyslipidemia, diabetes, and hypertension. They also screened for OSA, obstructive sleep apnea, and they initiated CPAP if indicated. Also, smoking cessation and alcohol abstinence was recommended for these patients. For liraglutide, they started dose of 0.6 once daily for at least 1 week, and then they doubled that to 1.2 for, again, at least 1 week to achieve kind of a target dose of 1.8 milligram once daily. Patient remained on liraglutide 3 months pre-ablation and 6 months after. Out of those 65 patients, there was 6 withdrawals. 5 patients changed their mind. They didn't want to do PVI anymore. And 1 patient, actually, the AF just kind of resolved with weight loss. And they kind of certified the results into group 1 where there was less than 3% weight loss. Some of them actually had weight gain, or group 2 where there is more than 3%, or 3 to 10% weight loss. And the outcomes, the AFib ablation outcomes after 3-month blanking period. So the blanking period results were not included, available for only 41 patients. So we ended up with 59 patients, mainly male, with a BMI of ranges between 30 to kind of 40, mainly persistent AFib, 80% persistent AFib. That's interesting, like although they are obese patients, but only 27% had diabetes. Hypertension was kind of predominant in 85%. And EF was either moderately reduced to 45% or normal up to 60%. So group 1, 29 patients, and group 2 were with the liraglutide, 30 patients. Group 1, they did have some weight gain, and if they had weight loss was less than 3%. in group 2, there was up to kind of 6% or 7% weight loss. It's unclear why group 2 they had early access to PVI compared to group 1, but not significantly, only like a couple of months. And the PVI was achieved in all patients. All veins were isolated. There was only one case of complication, which was pericarditis. Freedom from AFib in group 1 was only 57%, but in group 2 was 85%. And then they substratified to persistent AFib. So in persistent AFib, patients who received liraglutide and risk factor modification, they had freedom of AFib around 93% compared to risk factor modification only, which was 59%. So this is kind of in a press release paper. They didn't, or it was not clear how they measured the outcome, the AFib, what kind of screening or monitor tools they used. And this is the graph here. So mainly persistent AFib in both groups. And then 12 out of the 21 patients in group 1 didn't have AFib, and 17 out of the 20 in group 2, which is the 95% here, also did not have atrial fibrillation. And then they looked at changes from persistent AFib to paroxysmal AFib, or paroxysmal AFib to atrial flutter. Those kind of are non-significant numbers because they're just too small. The population is not as big either. And that's kind of one of the limitations of this study. Is just it gives us an idea that weight loss can lead success rate and improve it, and you can actively achieve that by adding medication to risk factor modifications. But bigger studies are still needed to confirm the results. I'll leave it now to my colleagues, Dr. Tan and Dr. Weng, to go on and present their studies.
was mute. Yeah. Sorry, everyone. So just heard there was no sound, so I'm just going to go through this again really quickly. I'll be talking about conduction system pacing and its role in cardiac resynchronization therapy. Just a bit of background, as you all know, about conduction system pacing, which has really come into into prominence in the last 6 to 7 years. Its role in pacing-induced cardiomyopathy in reducing hospitalization for heart failure, death, and pacing-induced cardiomyopathy. And of course, its role in cardiac resynchronization, mainly because it's able to recruit the fibers or the disease fibers by pacing at higher outputs. So there are 2 small randomized studies that have evaluated the role of His bundle pacing in CRT. Both recruited patients with an ejection fraction of less than 35%, left bundle branch block, NYHA class 2 to 4. And both trials showed similar results, with His CRT demonstrating improvements in ejection fraction, QRS duration, and NYHA class. However, the results are not superior to conventional biventricular pacing. There are some problems with His bundle CRT. The first of which is that there is significant crossover in both of these studies, with up to 48% or nearly half of the patients crossing over in the His CRT trial over to biventricular CRT. And in the His Sync trial, there was only a 72% success rate. In the His alternative trial, only a 72% success rate. And really, this is kind of reflective of the inability of His bundle pacing to correct distal left bundle branch block and intraventricular conduction delay. And consistent with the other trials of His bundle pacing, the thresholds are also significantly higher, and this could actually lead to early device battery depletion. Along with the rise in popularity of left bundle branch pacing, the attention then switched over to using left bundle branch pacing as a CRT modality. And in this study by Weng and colleagues in 2020, 63 patients with non-ischemic cardiomyopathy underwent left bundle branch CRT. Success rates were 97%. Successful left bundle branch implant occurred in 61 out of 63 patients. And unlike in His bundle branch pacing, there's excellent R-wave sensing, good pacing thresholds, and this persisted 1 year into the study. There was also very good QRS narrowing with significant improvements in the LVEF, reductions in LV and systolic LVESV, as well as improvements in NYHA functional class. So Vijayaraman and colleagues actually then looked at a population of all heart failure patients with an ejection fraction of less than 50%, both ischemic and non-ischemic, with indications for ventricular pacing and or CRT. And left bundle branch pacing was attempted in 325 patients. There was an 85% success rate. And in this population, 35% were women, 44% had ischemic cardiomyopathy. Left bundle branch block was present in 39%, but interestingly, non-left bundle branch block was present in 46%. In these patients, R-wave amplitudes were again stable, thresholds were low, and left bundle branch area pacing resulted in significant improvements in all echocardiographic and clinical parameters, with narrowing of QRS, improvement of NYHA class, improvement of LV end diastolic diameter, as well as LVEF. Improvement was also seen in patients with left bundle branch and no left bundle branch block, and 31% of patients were super responders with left bundle branch and non-ischemic cardiomyopathy predicting a better response. So up to this point, all the studies that were published were retrospective or observational.
أنا أقل presentation كلهم 20 slides or 50 slides. I'm like, and I have 12. I finished like in 10 minutes already.
Yasmeen, I think you need to turn off your mic. So I was just saying, up to this point, all the studies published were really retrospective or observational. And in September 2022, the first randomized controlled trial, the left bundle branch pacing resync trial, was published by Weng and colleagues. And this pitted left bundle branch pacing CRT against conventional biventricular pacing with a coronary sinus lead. This is a small study. It's only got 40 patients with ejection fractions of less than 40%, NYHA class 2 to 4, complete left bundle branch block. Patients with ischemic cardiomyopathy and non-left bundle branch block QRS were actually excluded, as were patients with persistent AFib. And the primary endpoint was a difference in the change in LVEF from baseline to 6 months between both groups. Secondary endpoints included echo parameters, NYHA functional class, and pace QRS duration. So in this study, 2 patients cross over from left bundle branch to BIV, 4 from BIV to left bundle branch for the technical reasons that we see over here. And in this study, left bundle branch CRT actually resulted in a greater improvement in ejection fraction from baseline to 6 months follow-up compared to BIV CRT. And this is consistent basically in both intention to treat as well as per protocol analysis. The adjusted mean change of from baseline to 6 months was 5.6% by intention to treat analysis and 7.5% as by per protocol analysis. And both left bundle branch pacing, and BIV CRT demonstrated improvements in all echo indices, NT-proBNP levels, 6-minute walk distance, NYHA functional class at 3 and 6 months, but there was no significant difference between both groups. So really, this leads us to today's study. Most of these studies so far have included patients with both his bundle as well as left bundle branch pacing. And in many of them, left bundle branch area pacing was actually kind of employed as a bailout strategy when his bundle branch pacing was not successful. But with the technical challenges and steeper learning curve of his bundle pacing, this has now gradually fallen out of favor, and left bundle branch pacing has now come to the forefront. So this study by DS and colleagues was basically presented this year. It's a prospective observational, unfortunately non-randomized multi-center study across 2 continents conducted between January 2020 and August 2022. It seeks to evaluate the role of left bundle branch area pacing exclusively as a first-line implant strategy compared with traditional biventricular pacing. The patients included were those basically fulfilling standard criteria for CRT implant. The study was not meant to evaluate left bundle branch as a bailout strategy, so all those patients with a failed CRT attempt were actually excluded. And the primary outcome of interest was the composite of all-cause mortality as well as heart failure hospitalizations. So 371 patients participated in this study. Patients were assigned to each arm based on physician and patient preference after a discussion. And eventually 128 patients underwent left bundle branch area pacing, 243 underwent biventricular pacing. You can see here that even though this is a non-randomized study, the baseline characteristics of the patient groups are basically very similar, apart from the fact that in the BIV arm, there are a higher number of patients with NYHA class 2. Compared to biventricular pacing, left bundle branch area pacing resulted in, number 1, shorter procedural times, 95 versus about 130 minutes, as well as shorter fluoroscopy times, 12 versus 21 minutes. Acute procedural success rates were lower in patients with left bundle branch area pacing than BIV pacing, 84 versus 95%, and this was significant. And here, when we talk about procedural success rates, we define it as left bundle branch capture during the implant procedure. So if they get left ventricular septal pacing, we don't count that as a successful procedure. And we'll talk about the reasons why there is a difference in the success rates later on in the presentation. And here are the results of the study. Basically, the primary composite outcome of all-cause mortality and heart failure-related hospitalizations occurred in 31 out of 128 patients, which is 24%, and it occurred in 42.4% in the biventricular pacing group. And left bundle branch area pacing was also associated with a relative risk reduction of about 38%, absolute risk reduction of 18.2% of the primary composite outcome. Now, if you take out all the patients with an unsuccessful implant, in other words, we define this here as a loss of left bundle branch capture in the patients in the left bundle branch group and loss of LV capture in the CS standard biventricular pacing group, then these outcomes are further strengthened. So if you analyze these results basically to patients with durable ECG evidence of conduction system capture, then the outcomes are further strengthened. In terms of secondary outcomes, there are higher rates of post-procedural NYHA functional class improvement, shorter QRS, higher post-procedural LVEF, and a greater EF improvement, all in favor of left bundle branch area pacing, and the results are significant. Patients with successful left bundle branch area pacing also had a significantly lower hazard ratio for the primary outcome as compared to patients who actually lost or did not get the left bundle branch. And this basically does show that the fact that you actually captured the left bundle branch actually does make a difference. In terms of safety outcomes, no significant differences in acute procedural complications in both groups. There was one pneumothorax and one LV septal perforation. The LV septal perforation resolved spontaneously. They just retracted the lead and repositioned it. There was no clinical consequence to the patient. There are also no significant differences in long-term device-related complications between both groups. As expected, 14 patients in the BIV group had some phrenic nerve stimulation. There are none, of course, in the left bundle branch area pacing group, and there are numerically higher number of procedure-related infections in the BIV group. It's not mentioned why, but obviously with the larger device and more leads, it's not surprising. So CRT is a well-established therapy for patients with heart failure, especially it's a class 1 indication for patients with EF of less than 35, left bundle, and NYHA 2 to 4. But there is up to a 30% non-response rate, and there are, of course, several LV lead-related complications, including dislodgement, phrenic nerve stimulation. Pacing through the coronary sinus also results in a non-physiological depolarization and repolarization sequence. And this study basically does add to the increasing body of evidence that left bundle branch pacing CRT is not only as effective, but also possibly superior to biventricular pacing, while circumventing the problems of his bundle pacing, which we have discussed earlier. Now, of course, there are some limitations to this study, mainly the fact that its numbers are still small. This is a non-randomized study. And also the fact that there is a 16% failure rate of left bundle branch area pacing compared to other studies, which touts a success rate of between 85 to 95%. There are several reasons for this. One of the possible reasons is that we're dealing here with patients with heart failure, dilated ventricles, and at the present moment, the tools that we are still using are actually basically targeted for his bundle pacing, and not really for left bundle branch area pacing. So there's certain manipulation that needs to be done for us to get there. And this distorted anatomy basically decreases our chances. And of course, the next problem, of course, is operator experience as well. Also unknown and from this trial is basically how left bundle branch pacing would perform in different cardiomyopathies, for example, amyloid hearts or sarcoidosis. We don't know the answer to that question. But, does this spell the end of the CRT device as we know it? Are we just going to put in, a single lead into the left bundle for everyone? This study was done in January 2020 by Jastrzebski and colleagues. We know that proximal left bundle branch pacing does have its limitations, right? In patients with a very dilated heart or very advanced heart failure, there is only so much that left bundle branch area pacing can do because of conduction disease that is distal to that, for example, in the His-Purkinje system or in the myocardium itself. At the same time, we know that conventional BIV pacing also has its desynchronization effects on myocardial pacing. So if you combine both left bundle branch area pacing and biventricular pacing, like this study, it's possible that we could improve outcomes. And in this LOT CRT study over here, 112 patients, successful in 81% of these patients. Don't forget, we're dealing with very dilated hearts here. It actually resulted in significant narrowing of the QRS complex, better than either biventricular CRT or left bundle branch area pacing. And there were also, echocardiographic responses and NYHA class improvements as well. So to conclude, I think left bundle branch area pacing may be associated with better ECG, echocardiographic, and clinical outcomes when compared to biventricular pacing. Left bundle branch pacing is also technically simpler and associated with a shorter procedural and fluoroscopic time compared to biventricular pacing as well as his bundle pacing, and it also has a comparable safety profile. But of course, further large randomized control trials are required. There is one coming up, the left versus left RCT, and it's going to start recruiting at the end of this year. And there remains a role, of course, for combining left bundle branch area pacing with biventricular pacing, especially for patients with advanced heart failure as well as conduction system disease. So that's the end of the late-breaking clinical trial, but I just wanted to point out as well that we do have a new guideline that was released at HRS with regards to cardiac physiological pacing. It's a 72-page document, but just to highlight a few of the more important points. For patients, we all know the indications for pacemaker therapy, but this basically added the role of physiological pacing into the guidelines. Now, obviously, at the time of cardiac surgery, if you anticipate the patient is going to be pacing dependent and is going to need a CRT, then it makes sense to put in an LV epicardial lead. For patients who need pacemaker therapy, you then need to stratify them into whether they're going to be substantially pacing in the ventricle. So substantial here refers to more than 20 to 40%. So if the answer is yes, then his bundle or left bundle branch area pacing does play a role in patients with EF of 36 to 50%. Physiological pacing is most likely to preserve or improve EF when pacing requirements are substantial. So that has been included in the guidelines. It is not clear which patients with a normal LVEF will develop pacing-induced cardiomyopathy. So it is acceptable to choose cardiac physiological pacing when pacing requirements are expected to be substantial. So that goes into the guideline as well as a 2B indication. Of course, if you're putting a his bundle lead because it's so unstable, they recommend putting in a backup lead. So no one ever does that now. So we kind of leave that out. For patients with, who are not expected to be substantially ventricular pacing dependent, then it gets a bit more muddy. The clinical benefits of conduction system pacing have, predominantly been observed in patients with substantial pacing burden. So it's difficult to kind of extrapolate that to patients who are not pacing dependent. I think basically the guidelines just go on to say that if you anticipate that the patient is going to require substantial pacing in the future, then you might want to consider conduction system pacing or physiological pacing as a whole. This is a very complicated slide. I'm not going to go through this here. Basically, this is all the CRT trials that have been published over the last years, now incorporating conduction system pacing as well, and its role as a bailout strategy, as well as in patients where it can be considered when the indications are not so clear. Like, for example, in patients with non-left bundle branch or in patients with a QRS of 120 to 150 milliseconds, whereas CRT has not been shown to be completely beneficial. I'm not going to go through this in detail, but these are basically all now available on the new guidelines. So with that, I'm going to hand over my time to Willy to continue with pulse field ablation. Thank you.
Okay, hi everyone. So I have the privilege of being able to give you some updates on pulse field ablation. I was fortunate to be able to attend the conference in New Orleans this year. I have no disclosures, but I do have to say that the therapy being discussed today is not FDA nor Health Canada approved. It's only available in study circumstances in North America. Okay, so three main objectives today is one, what is pulse field ablation? I don't know how much of this has been disseminated to kind of non-EP cardiology, so we'll go over that quickly. The second is to go over the theoretical benefit of pulse field ablation and kind of explain why all the EPs are so excited about this. And the third is to show you some of the human data that's been available. So what is pulse field ablation? This really all comes down to the concept of electroporation. And what that means is that we know that if we expose cells to a high voltage field, even transiently, it disrupts the cell membrane. It's not completely understood why this happens, but essentially applying a high voltage field across will actually induce pores in the cell membrane. The phospholipids actually rearrange themselves. It's been used for many, many years in cellular work to transiently cause pores and then basically float either drugs, dyes, or even DNA into cells, and then allow the cells to repair themselves. So not to kill the cells, but just to put molecules inside the membrane. We also know that by exposing cells to either more energy, which is on the vertical axis, or exposing them to energy for a longer duration of time, which is on the horizontal axis, we can actually cause not just reversible electroporation, but irreversible electroporation. And if we crank up the power, then we can actually cause thermal damage. So this is where the concept of irreversible electroporation comes into play. So on the bottom, we have a traditional electroporation technique. We basically permeabilize the cell to introduce things, and then let the cell recuperate. On the top, though, if we increase the amount of energy, both amount and duration of energy applied, then it can actually lead to irreversible cell damage and cell necrosis. This has been studied for many years in oncology, so they actually have techniques where they'll introduce metal rods percutaneously and surround solid tumors and deliver this electrical field to cause irreversible electroporation damage to the tumor cells. As well, it also causes the tumor cells to become more permeable to chemotherapy, so it also enhances the delivery of chemotherapy. So how is electroporation used in the heart? So instead of applying a large current across a large amount of tissue, what they've started to do is they essentially use catheters, so similar platforms to what we already use for traditional ablation. But instead of applying traditional RF energy, which basically heats up the tip of the catheter and causes thermal destruction, we deliver high voltage fields through the catheters and through the little electrodes on the catheters and cause a high voltage field locally. So in terms of energy delivery, there's multiple ways we can do this. We can do unipolar or bipolar delivery. So unipolar, essentially creating a field from the catheter tip to a grounding pad, and bipolar creates a electrical field between the adjacent electrodes on the catheter. We can also vary the amount of energy that's delivered. We can use monophasic or biphasic pulses, similar to what we already do for external defibrillation. The pulses are delivered in little packets, so it's not good to expose the cells to a high voltage for a long period of time because we get undesirable effects, for example, electrolysis and more thermal damage. So they basically are delivered in nanoseconds and milliseconds in little trains, and then they're packaged into packets, and then there's spacing between the packets so that the cells don't get too hot. This is a live demonstration actually of a PFA lesion being delivered. So we see there's 5 trains being delivered there, and the lesion's done. If you've ever seen in the EP lab what we do with traditional ablation, the lesions go anywhere from 7 seconds all the way up to 90 seconds, and this takes less than 2 seconds per PFA lesion. Okay, so now that we've gone over the what electroporation is and what pulse field ablation is, we can go over the theoretical benefits. So I'd say the main reason why everyone is so excited about PFA is this concept of tissue selectivity. So obviously when we ablate, we want to make sure we only destroy the tissue that we intend to destroy without injuring adjacent tissues. So the theoretical benefit of PFA is that it ablates the cardiomyocytes underneath the catheter, but it actually preserves adjacent cardiomyocytes and also, very importantly, preserves esophageal smooth muscle cells, other vascular smooth muscle cells, and nerves. This is data from rats. On the left side, we have NRVM, which is actually just ventricular myocytes. We have SMCs in the middle, which are smooth muscle cells, and RCNs are cortical neurons. So we see as we apply a voltage field across, the percent of cells that die is actually much higher with myocytes compared to smooth muscle cells and neurons. And in fact, when we move the field just 1 millimeter away, this cell activity becomes even more enhanced. Now, they've done pig studies where they put a balloon into the esophagus and crank it towards the IVC, and then they introduce catheters up into the IVC and deliver ablation. So they compare PFA on the left side to traditional radiofrequency ablation on the right side. These images speak for themselves, but essentially on the left side we have very little gross evidence of damage, whereas on the right side we have a fistula. These pigs were sacrificed at 25 days. And not surprisingly, when we look histologically, on the top, again with PFA, there's little disruption to the layers of the esophagus with preservation of arteries and nerves. On the bottom, we have the sequelae of radiofrequency ablation, so obviously catastrophic damage. Again, sacrifice at 25 days. This is unpublished data they showed at the conference, actually, where they delivered PFA lesions directly to the esophagus. So you do see there is some injury, there's some inflammation around the esophagus, but within 2 weeks or a month, all histological and gross evidence, there's no evidence of permanent damage. The theory behind this, again, it's not super well understood, but the theory is that electroporation causes the cells to die, but it maintains the extracellular matrix, so it allows progenitor cells to come in and recover and repair the esophagus. This is now they're ablating through the aorta, but same thing. They're looking at the damage in the esophagus. You see in the middle here that with PFA, there's very little temperature change because, again, the amount of energy being delivered through these tiny, tiny packets of energy, electricity is actually quite small. And then you see on the bottom here, traditional radiofrequency ablation, the temperature can vary quite a bit. We do have some, this is early data from when they were first trying out PFA in Europe, and this is in humans, and they do CMR studies, and they show that after a cryo radiofrequency ablation and pulse field, you do see late GAD enhancement in the atrium, but remarkably, you see the enhancement also in the esophagus for cryo and radiofrequency ablation. So just we don't see, even if we don't see, clinically see ulcers or fistulas, there is some damage to the esophagus always being done. Whereas you see on the right side with pulse field ablation, there's no LGE. So what about pulmonary vein stenosis, which, as we know, is another complication of traditional AF ablation? So what they did here, this is a dog study. They applied the ablation to the upper veins and then left the lower veins intact as a control. And you see on the top row here, that's traditional radiofrequency, and on the bottom, that's PFA. So the images speak for themselves, but remarkably little stenosis with PFA lesions. And these are lesions delivered into the pulmonary vein on purpose. So no surprise, the traditional ablation causes marked stenosis in the veins. So now that we've gone over the theoretical benefits, I'll show you some human data. Hopefully convince you guys that this is something worth thinking about. So what is available? There's actually, as far as I'm aware, there's only one PFA system that's actually commercially available for non-study routine clinical use. This device is CE marked in Europe. It's called the FARAPulse system, and it's delivered by Boston Scientific. There's essentially you can choose one of two catheter sizes, and then each of the catheters you can manipulate to develop either a flower shape or a basket shape. And you see in the middle panel here, the basket configuration allows the catheter to go deeper inside the vein, and then putting in the flower configuration allows ablation of the antrum. And I should mention, it's not just one lesion per vein. We do, I should say, they do a couple of lesions inside the vein and then a couple of lesions on the antrum, between 6 to 8. So with any new technology, the first question is it safe? So this is they call the Manifest survey. So they survey all 24 centers in Europe that have started doing PFA. They had a 100% response rate, and they say they got the data from 100% of patients who underwent PFA. So about 1,700 patients. A couple interesting things here, 82% perform with sedation. So in Europe, they don't have access to anesthesia as much as North America. So the majority actually are performed with just deep sedation. Procedural time about an hour. And, the average age of the patient, 65, nothing out of the ordinary here, about 65% paroxysmal, 30% persistent. This is their initial 6-month safety data, so all fairly reasonable. Transient phrenic nerve paralysis, 0.5%. We'll keep an eye on that because that'll come up again later. About 1% chance of pericardial tamponade, 0.4% stroke. This is the 1-year safety data, so kind of similar. You'll see there is one phrenic nerve injury, which I'll show in the next slide. But otherwise, in fairly reasonable complication rates. It's important to pay attention to the ones that are potentially related to PFA, not the ones that are possibly related to, let's say, vascular access or even transseptal access. So this is actually they think that there's been about 20,000 PFA patients done in Europe, and this is the only reported complication of persistent phrenic palsy. So it's something to keep an eye out for. They also looked at the complication as a function of number of procedures done at each center temporally. And visually, we see that, especially the tamponades, they tend to happen earlier in operator experience. And as the more cases get done, the rates looks like it visually anyways on this graphic does appear to decrease. They think the reason twofold. The one reason is that this pulse catheter system is delivered over the wire. So they put a wire into the pulmonary vein and slide the PFA catheter over that. That's quite different than our approach for traditional RF ablation, where we just go in with the catheter. So there was a bit of a learning curve, especially with centers that only used RF. And initially, when they used the wires, it was a straight tip, non-J tip. So they figured out that that may have been leading to more tamponade. So they actually switched to a J tip wire, and that also decreased the rates of tamponade. This is a prospective safety registry established. It's 7 of the centers, and I believe these 7 are included in the 24. So this is not entirely unique data, but it's prospectively registered. And this specific analysis comes from patients done between March 2021 and May 2022. 7 high volume center, 42 operators. So this on the left side is the operator spread per center. And on the right side, interestingly, they show kind of how many of their operators are brand new, how many are kind of 2 to 5 years, so still junior, and then how many are experienced. They also separated the efficacy and complication rate by operators' primary mode prior to PFA, so whether or not they were traditional cryo users or traditional RF ablation users. So overall, these were the overall complication rates. So again, nothing unreasonable here, about 1% tamponade and about 0.4% stroke. And we see that persistent phrenic nerve dysfunction again in the middle here. They separated, they did some analysis again by how long operators have been practicing. The younger operators used a bit more fluoro, but other than that, there wasn't any significant differences in complication rates. Again, they also separated by whether or not operators were primarily cryo users or RF users. The platform of PFA is it's better suited for people who are used to cryoablation, because in cryo we do the same thing. We put a wire up and then we deliver the balloon over either a wire or a mapping catheter. So we see here actually cryo operators were quicker, used less fluoro, and also there was the rates of tamponade were lower in operators who use cryo balloons. This is the system that was studied by Atul Verma in many North American centers. So the study looked at 9 countries, 41 centers. 4 centers were in Canada, and a total of 17 enrolled patients. This system is made by Medtronic. And they published results this year in Circulation. It's non-randomized, but it's a prospective study with a regimented procedural design. The baseline characteristics again are reasonable, 64 years old. I haven't shown the persistent paroxysmal spread here, but reasonable compared to other trials. And their safety was quite good. Now, they only had 300 patients, but they had a single stroke in the paroxysmal group and a single case of tamponade in the persistent group. And just as a reference to traditional AFib ablation, these are 2 recent large meta-analyses of 25,000 Australian and New Zealand patients on the left, and then a meta-analysis actually just came, I think, last month out of the Montreal group for about 13,000 patients. We see the rates of stroke are about 2.24. And tamponade approaching 1%. It's hard to compare the like for like with PFA in absence of a head-to-head trial, but I just wanted to give an idea of what kind of complication rates we're used to. So now that we've gone over some of the safety data, I'll show you some of the efficacy data. This is a single center experience, a center in Frankfurt that started doing PFA. And this is just routine clinical follow-up. This is not a study protocol, so there's not regimented loop monitors or, I don't remember, actually, I don't think he said what they do for Holters, but this is a kind of, we call this real life experience. And you see the recurrence rate after a year is about 80% in paroxysmals and 66% in persistence, which is not unreasonable. On the left side here are the two of the outcome curves for pulsed. So the primacy efficacy in PULSE, which was again a Toverma study, composite of procedural failure, arrhythmia recurrence, or anti-arrhythmic escalation at 1 year. So I think there was quite some disappointment that it was only 66%, but the argument the study authors made was actually pretty similar to the results from prior traditional ablation studies. So on the top right, we have the study at a UBC early AF, which is cryoablation, and we have the Cabana outcome curves on the bottom right, which is traditional RF ablation. So when putting that into context, actually at 1 year, it does look visually similar. Again, in the absence of head-to-head trials, it's difficult to make true comparisons. In the manifest PF survey, this is real life data, not a prospective cohort, but about 78% freedom from AFib at 1 year. And this is from the Euphoria registry, which is the prospective 7-center registry in Europe. And again, about 75%, so not unreasonable. And there's ongoing trials. So the Advent trial, which is the Farapulse study in the States, it's actually finished enrolling. So we're just waiting for follow-up. And it aims to look at comparing standard of care randomized against pulsed field ablation using Boston's catheters. And then the BEAT AF is a study in Europe. I don't think it's actually started enrolling yet. And the last interesting slide I'll show is it efficient? So once we've established safety and efficacy, can we do them faster? So this is, again, single center experience, and this slide is lifted directly from their presentation. So it's unpublished data, but in their first 495 cases, you see that the procedural times fall at the beginning and remain quite low. So 35 minutes is certainly encouraging. There's a couple of, there are things that need to be answered. There's the issue of, can we use PFA outside the left atrium? There's a promise in ventricular tachycardia, so doing thicker tissue. They've actually developed PFCA catheters, so cryo catheters that when the catheters get really cold, they stick to the heart, and then they deliver PFA through that catheter. So it allows kind of thicker delivery of energy. There's the issue of microbubbles. So when you apply high voltage across water, it actually creates oxygen and hydrogen at both ends. And on intracardiac echo, we do see microbubbles with PFA delivery. So, with these registries, some of them do MRIs routinely, and there's been about a 10 to 20% rate of asymptomatic MRI lesions. But when they've gone back to look at traditional RF, that number can go up as high as 50, 60%. And the last is vasospasm. So this pulse field energy can stimulate either nerves or even the cells directly. So here's a slide showing during PFA. This is they're doing a CTI line, which is really off-label, and you see that there's RCA spasm during energy delivery. Now, in the safety registry reports, people did do quite a bit of CTI, and they report that they only have a couple cases of actually significant, like ST elevation or chest pain, and these are all relieved by nitro. And in fact, now what they do is they give nitro preemptively, and they report that there's no spasm seen anymore. So in conclusion, PFA appears to be effective and safe. There's a potential for an enhanced safety profile compared to traditional ablation. For now, it's limited to left atrial, and of course, we don't have long-term data, and we don't have comparative head-to-head data against traditional ablation, but certainly, in my opinion, it's a very promising technology. So with that, I'll say thank you, and happy to take questions.
Thank you to all the speakers this morning. If you have questions, either raise your hand and I'll give you the microphone here in the room, or you can add to the chat box on MS Teams. There's a couple questions from Dr. Beanlands. The first is about atrial fibrillation. So should our patients be referred for ablation, or should our patients being referred for ablation be referred for prehab in advance to achieve weight loss before their AF ablation?
So there is an ongoing study being run out of Halifax, but we are an enrolling center, the RASTA AF study. So it randomizes patients to a structural exercise program and a loop monitor, actually, to keep an eye on things. So I think it's a good idea, and it certainly hasn't been robustly proven by evidence, but we're hoping to show that. So a little plug-in for that study.
Next question from Dr. Beanlands. He had a question about efficacy, which I think you addressed, Willy. But the second question was, in our center, are we looking at LGE in the esophagus post-procedure? Have we done that safety assessment here?
That I'm not sure. I'll redirect that to our.
Yeah, so his question is, are we looking for LGE for, micro perfs or things like that, I suppose? Not to our knowledge. Okay. I have a question about the pacing, the left bundle pacing. So in heart failure, we like to give folks beta blockers, and we like to drive, try and get them on, guideline directed target doses, and we're often limited by heart rate, particularly in some folks that just have intrinsic, conduction system disease, sinus node disease. So to your knowledge, and I've always had this, often had this discussion with some of the EP staff, is there evidence that we should, put in a pacemaker, left bundle pace to allow us to get to target doses for our beta blocker?
So it's a reasonable question. It depends on multiple factors. I think one of them is going to be what the conduction system looks like to begin with. It is an indication to put in a pacemaker for a patient who is limited by their heart rate and unable to get to goal-directed medical therapy. What type of pacemaker you put in, it depends on their AV node conduction. If it is a sinus node dysfunction, normally using the conduction system of their own patient is always going to be most efficient, assuming it is a normal functioning conduction system. If they already have, conduction disease and you want to try to correct it, then, either left bundle or CRT in a patient who's going to become pacing dependent is not unreasonable. It's very rare for us to put in a pacemaker for a patient whose heart rate, let's say, is at 50, and we haven't tried the medications. If we try the medications, they are unable to tolerate it, then I think it's not unreasonable.
Okay, and another question regarding the AFib and obesity, which is a story that's kind of been around for a while. Is it the GLP agonist that is the that is targeting a pathway that reduces AFib, or is it purely the weight loss? A bit of a chicken or egg, but does it matter how the weight loss occurs that results in the improvement in the AFib burden, or is it the drug that's resulting in the reduction in AFib burden? So mechanistically, I guess, is my question.
Not sure if Steve did.
I mean, we have good data that weight loss, irrespective of how you do it, is associated with better outcomes post arrhythmia management, whichever arrhythmia management you pick. And there's good data showing that obesity is overall associated with increased burden of arrhythmia, along with, same with alcohol intake. In terms of how you choose to lose the weight, I think the data is very similar between the groups. We consistently see weight loss is associated with better outcomes, irrespective of how you do it. Whether GLP-1 has an additional pathway to improve that one, I don't think is clear yet. But weight loss alone, no matter how you do it, is good. Which goes back to Dr. Beanland's, I think, question of prehab for overweight patients. I think it is always a good idea to refer the patients simultaneously if you think they're overweight to both EP and the pre-app for weight loss, because typically they stay on the wait list for, most of us, if your BMI is over 35 or 40, would probably talk to the patient to try to lose weight while you're on the wait list to improve the outcomes.
There's a question from Dr. Chan. So based on physiology, should we be aiming for his bundle or left bundle branch pacing in all patients that require pacing?
I'll take that question. I think in terms of physiology, even though left bundle branch area pacing is shown to have a slightly longer QRS duration, the challenges of His bundle pacing, mainly related to the technical difficulties in getting to the His, the high thresholds, the low R wave sensing, have basically resulted in His bundle pacing essentially pretty much falling out of favor. Left bundle branch area pacing has been shown to achieve physiological pacing that is as good or if not better than His bundle pacing. So nowadays, I think most electrophysiologists actually go for left bundle pacing straight off rather than His bundle.
Okay, and maybe one last question. So regarding the PFA, one, does our center have experience with it? And two, if so, what were your procedure times like? Because it seems to me if it's markedly quicker and we have such a long wait list, is this going to be a viable option to improve efficiency going forward?
Yeah, so no, we don't have any experience with PFA yet, but certainly that's one of the tantalizing benefits of PFA is the very quick procedure time and the very short left atrial dwell time. But no, we don't have any experience here yet.
Procedural times are not hugely different between, the newer RF technology and techniques and what we use compared to PFA. The only part would be if you need general anesthesia or not for the procedures. That may shave down quite a bit because you still have to wait after the PFA. Even the times it takes 20 minutes to, let's say, isolate and finish off everything, but you're still waiting. You have to still map for most of the procedures. So they have 40 minutes versus I think 60 minutes is the total thing, but I'm not sure if it'll revolutionize, the wait list down to 10 patients. Yeah.
Great. Okay, I want to thank our speakers today. Thank you very much for the update. Please sign up for the medical staff meeting next week. That's for all the physicians on staff. And then we'll see you the week after that for M&M rounds. Have a good week.